We're going to start out with urinary. So to locate the kidneys on your own, you want to stand erect and put your hands on your hips with your thumbs meeting over your backbone. When you are in this position, your kidneys will lie above your thumbs on either side of your spinal column, but their placement is going to be a little bit higher than you would think. The right kidney does touch the liver, therefore it does lie a little bit lower than the left. Both kidneys are protected a bit by the lower posterior part of the rib cage and are located underneath the muscles of the back and behind the parietal peritoneum, which will also make it known as retroperitoneal. You have a heavy cushion of adipose tissue or the renal fat that normally encases each kidney and helps hold it in place. The kidneys resemble lima beans in shape, roughly oval with a medial indentation, and the medial indentation called the hilum. That is where the vessels, nerves, and the ureter connect with the kidney. An average kidney measures approximately 11 by 7 by 3 centimeters. And there's a tough fibrous capsule that forms the exterior wall of the kidney. And if you were to slice through a kidney from the side and open it like the pages of a book, then you would see the following structures. You have the renal cortex, which is the outer part of the kidney, the renal medulla, which is the inner portion of the kidney, the renal pyramid, the triangular divisions of the medulla on top of the kidney, extensions of that cortical tissue that will dip down into the medulla between the renal pyramids are called our renal columns. You'll have your renal papilla, which is a narrow innermost end of the pyramid, and your renal pelvis, also known as the kidney pelvis. And there is an extension of the upper end of a ureter, which is the tube that drains the urine into the bladder. And then lastly, you have your calyx, which is the division of the renal pelvis, and the papilla of the pyramid opens into each one of those calyx. More than 1 million microscopic units called nephrons will make up each kidney's interior. The shape of a nephron is unique, unmistakable, and admirable that is suited to its function of producing urine. It looks like a tiny little funnel with a very long stem, but it is an unusual stem in that it is highly convoluted, meaning that it has many fins. The nephron is composed of two principal components. You have your renal corpuscle and the renal tubule. So the renal corpuscle can be divided into can be subdivided into two parts. The glomerular capsule, which is also known as the Bowman's capsule, is a cup-shaped top of a nephron. And then the hollow sac-like glomerular capsule will surround the glomerulus. Now that glomerulus is going to be a network of blood capillaries that are tucked into the glomerular capsule. And the afferent arteriole is a small artery that delivers blood into the glomerulus and it is larger in diameter than the efferent arteriole that drains blood from it, and it's relatively short. So this partly explains the high blood pressure that exists in the glomerular capillaries, and this high blood pressure is required to filter the waste from your blood. The renal tubule is subdivided into 4 regions or segments. So you have the proximal convoluted tubule, or the PCT. That is going to be the first segment of a renal tubule. It's called the proximal because it lies nearest the tubule's origin from the glomerular capsule, and it is convoluted because it has several different bends. The nephron loop, or the Henle loop, that is the extension of the proximal tubule into the renal medulla. If you observe that the nephron loop consists of a straight descending limb, a hairpin turn, and then a straight ascending limb. The distal convoluted tubule, or the DCT, that is the part of the tubule that is distal to the ascending limb of the nephron loop, and it extends from the ascending limb to the collecting duct. And then your collecting duct, that is going to be a straight part of the renal tubule, and the distal tubules of several nephrons will join to form a single collecting duct. Your kidneys are going to be vital organs, and they are going to perform work that is essential for homeostasis and the maintenance of life. Early in the process of our urine formation, fluid, electrolytes, and waste from metabolism will be filtered from the blood and enter the nephron. Additional waste may be secreted into the tubules of the nephron, while substances that are useful to the body are reabsorbed into the blood. Normally, the kidneys balance the amount of many substances that are entering and leaving the blood over time so that the normal concentrations can be maintained. In short, the kidneys will adjust their output to equal the intake of the body. By eliminating your waste and adjusting fluid and electrolyte balance, the kidneys will play an essential part in maintaining our homeostasis of the whole body. An important function of the kidneys is going to be the secretion of EPO, or the erythropoietin. As a response to hypoxia, a deficiency of oxygen in the blood, the erythropoietin is going to be released into the bloodstream. Your EPO travels in the bloodstream to the red bone marrow, where it then stimulates the production of those additional erythrocytes. The additional erythrocytes will increase the ability of the blood to absorb and transport oxygen to oxygen-starved tissues. So EPO is sometimes used as a drug to treat anemia that's caused by critical illnesses such as cancer. It's also sometimes abused by athletes that are attempting to improve their athletic performance by boosting their hematocrit, therefore increasing the oxygen carrying capacity of their blood. The kidney's 2 million or more nephron will balance the composition of the blood plasma, and therefore it will help maintain a homeostatic consistency for the entire internal environment of the body. In performing this critical function, then the kidney's nephrons must flush out the excess waste or waste molecules by excreting urine. The nephrons will form urine by way of a combination of 3 blood balancing processes. Your urine formation will begin with a process of filtration, which goes on continually into the renal corpuscles. Blood will flow continuously through the glomeruli and exert pressure, and this glomerular pressure is high enough in order to push water and your dissolved substances out of the glomeruli into the glomerular capsule. Briefly, your glomerular blood pressure will cause filtration through the glomerular capsule membrane. And if the glomerular blood pressure drops below a certain level, then filtration and urine formation cease. So hemorrhage, for example, may cause a precipitous drop in blood pressure followed by your kidney failure. Your glomerular filtration normally occurs at the rate of 125 milliliters per minute. So as a result, about 180 liters of glomerular filtrate is produced by kidneys every day. We don't actually excrete 180 liters per day, but most of that fluid will leave the body by glomerular filtration, will return to the blood by the second process, which is reabsorption. Reabsorption is the movement of substances out of the renal tubules into the blood capillaries that are located around the tubules. So your water, glucose, and other nutrients, as well as sodium and other ions, are substitutes that are reabsorbed. Your reabsorption begins in the proximal convoluted tubules and continues into the nephron loop, the distal convoluted tubules, and then your collecting ducts. Large amounts of water will be reabsorbed by osmosis through the proximal tubules. So in other words, roughly 2/3 of that 180 liters of water that leaves the blood each day by that glomerular filtration will return to the blood by proximal tube reabsorption. So the proximal tubules also reabsorb about 2/3 of most of our ions, as well as nearly all of the small organic molecules. And then secretion, that is going to be the process by which your substances move into urine in the distal and collecting ducts from the blood and the capillaries around these tubules. In this respect, your secretion is reabsorption in reverse. Whereas reabsorption moves substances out of the urine into the blood, secretion is going to move substances out of the blood into the urine. So your tubular secretion That will serve as an important function by removing or clearing the blood of excess potassium and hydrogen ions. Certain drugs, including penicillin and phenobarbital, and numerous wastes such as urea, uric acid, and creatinine. Most of our substances that are secreted from the peritubular blood will enter the filtrate primarily in the proximal tubule and to a lesser extent the distal convoluted tubule and collecting ducts. The major exception to this rule of thumb is going to be your potassium ion, which is going to be secreted primarily into the collecting duct and in exchange with sodium. Urine volume of potassium ions will vary greatly with diet. So in the distal convoluted tubules and your collecting ducts, your sodium secretion is dependent on the hormone, which is also important in regulating your urine volume. And then ammonia is going to be secreted passively by diffusion. So the body has ways to control the amount of composition of urine that it excretes, and it does this mainly by controlling the amount of water and dissolved substances that are reabsorbed by the kidney tubule. An example of your regulating water reabsorption in kidney tubules will involve a hormone called antidiuretic hormone, or ADH, that is secreted by the posterior pituitary gland. That ADH decreases the amount of urine by making collecting ducts permeable to water. The hormone aldosterone that is secreted by the adrenal cortex, that plays an important part in controlling the kidney tubules reabsorption of sodium. Primarily, it stimulates the tubules to reabsorb sodium at a faster rate. Secondly, the aldosterone also increases tubular water reabsorption because water always follows sodium by osmosis whenever it is possible. The term for salt and water retaining hormone, therefore, is a descriptive nickname for aldosterone. So like ADH, our aldosterone will reduce our urine volume. Another hormone, your atrial natriuretic hormone, or ANH. This has got some really hard words in here this week. Those are secreted from the heart's atrial wall, and that's going to have the opposite effect of your aldosterone. So ANH is going to be the primarily atrial natriuretic peptide, or ANP hormone within humans. The ANH stimulates kidney tubules to secrete more sodium, and therefore we're going to lose more water. So ANH is a salt and water losing hormone. Therefore, ANH is going to increase our urine volume. Sometimes the kidneys will not excrete normal amounts of urine as a result of the kidney disease, endocrine imbalances, cardiovascular diseases, stress, or a variety of other conditions. Some terms you may see in relation to abnormal amounts of urine are anuria, which is the absence of urine, oliguria, which is a scanty amount of urine, and polyuria, which is an unusually large amount of urine. So because the change in urine volume or output is a significant indicator in many different types of fluid alterations and diseases, measurement of both fluid intake and fluid output over a specified period of time is going to be a common practice within clinical medicine. So the normal adult urine output is 1,500 to 1,600 milliliters each day. Once urine is formed by the kidneys, then it must be eliminated from the body. Our discussion will now return to a focus on anatomy as we discuss the plumbing that's needed to drain our urine away. So the urine drains out of the kidneys into the renal pelvis and down the ureter into the urinary bladder. The renal pelvis is going to be a basin-like upper end of the ureter that's located within the kidney. Those ureters are going to be narrow tubes that are less than 1/4 inch wide and will be anywhere from 10 to 12 inches long. The empty urinary bladder will line the pelvis just behind the pubic symphysis. And then when it is full of urine, it will project upward into the lower portion of the abdominal cavity. So in women, it sits in front of the uterus, whereas in men, it rests on top of the prostate. elastic fibers and involuntary muscle fibers within the wall of the urinary bladder will make it suited for expanding to hold variable amounts of urine and then contract to empty itself. The lining is loosely attached to the deeper muscle layer so that the bladder is very wrinkled and it lies in folds called rugae when it is empty. So to leave the body, our urine passes from the bladder down the urethra and out of its external opening, which is called the urinary meatus. In other words, the urethra is going to be the lowest part of the urinary tract. So the urinary tract is a narrow tube, only about 1.5 inches long for a woman. However, in a male, it's about 8 inches long. So in a man, the urethra has 2 different functions. It's the terminal portion of the urinary tract, and then secondly, it's the passageway for the movement of the reproductive fluid semen from the body. In medical terms, micturition, urination, and voiding all refer to the passage of urine from the body or emptying of the bladder. So 2 sphincters will act as valves that guard the pathway leading from the bladder. The internal urethral sphincter is located at the bladder exit. And then the external urethral sphincter circles the urethra just below the neck of the bladder. When contracted, both sphincters seal off the bladder and allow urine to accumulate without leaking to the exterior. The internal urethral sphincter is involuntary, and the external urethral sphincter is composed of striated muscle, and that is under voluntary control. The muscular wall of the bladder will permit this organ to accommodate a considerable volume of urine with very little increase in pressure until a volume of 300 to 400 milliliters is reached. As the volume of urine increases, the need to void may be noticed at volumes of 150 milliliters, but micturition in adults does not normally occur very often below volumes of 350 milliliters. As the bladder wall stretches, then your nerve impulses are going to be transmitted to the second, third, and fourth sacral segments of the spinal cord, and then that emptying reflex will be initiated. The reflex causes your contraction of the muscle in the bladder wall and relaxation of the internal sphincter, and then urine will then enter the urethra. If the external sphincter, which is under voluntary control, is relaxed, then your micturition will occur. Voluntary contraction of that external sphincter will suppress the emptying reflex until the bladder is filled to capacity with urine, and then loss of control occurs. Contraction of this powerful sphincter is also it is also able to abruptly terminate urination voluntarily. High centers of the brain also function in micturition by integrating bladder contraction and internal and external sphincter relaxation with cooperative contraction of the pelvic and abdominal muscles. Urinary retention is going to be a condition in which no urine is voided, and the kidneys produce urine, but the bladder, for one reason or another, cannot empty itself. In urinary suppression, that opposite is true. The kidneys will not produce any urine, but the bladder retains the ability to relieve itself. In urinary incontinence or enuresis, then that will refer to involuntary urine, involuntary voiding, or the loss of urine. It most commonly does often occur in an older child or an adult. So you have urge continence that's going to be associated with smooth muscle overactivity within the bladder wall. Stress incontinence, which is often used to describe the type of loss that is associated with laughing, coughing, or heavy lifting. Overflow incontinence, that can be characterized by intermittent dribbling of urine, and it results from urinary retention and an over-distended bladder. Your reflex incontinence, that occurs in the absence of any sensory warning or awareness, and it is common in nervous system disorders such as your stroke, Parkinsonism, and your spinal cord injury. And then your nocturnal enuresis or bedwetting, That often occurs in a child who is beyond the age where voluntary bladder control is expected. The physical, chemical, and microscopic exam of the urine, that is termed urinalysis. So like blood, your urine is a fluid whose study can reveal much about the normal and the abnormal functioning of the body. So changes in the normal characteristics of urine or in the appearance of abnormal urine characteristics may be a sign of diseases. And then in clinical and lab situations, the standard urinalysis is often referred to as a routine and microscopic urinalysis. The routine portion is a series of physical and chemical tests, whereas your microscopic portion, that refers to the study of urine sediment within that microscope. This series of your lab tests will provide the variety of information that's often necessary for a physician to make a diagnosis. So you've got some word roots here. Most of them will look familiar to you. So reno and nephro. And then you've got your glomerulo, which is for your glomerulus. Hyalo, which is going to be for that renal pelvis, and then calio for that calix. For the urinary tract, you have uro and urino, which are both for urine, uretero for ureter, cysto for the urinary bladder, vesico for your urinary bladder, and then urethro for your urethra.